not to delve too far, we looked at a chart and just modified it slightly to be more accurate of the normal menstrual cycle.
And I guess that's a good segue into a non-systematic review that we like to do of the evidence. And you'll get a good idea of how we treat this condition, which is, surprise, surprise, via individualized medicine and shared decision-making.
Absolutely. One question just before we get into the symptoms and how this is diagnosed. Is PMDD a psychiatric condition or a women's health condition?
That's a tough one. I suppose you could ask the same thing about a lot of different conditions. I guess if I'm answering the question seriously, then I see PMDD mostly as a hormonal pathology, just like menopause. I believe they used to call it hysteria, hyst for uterus, like a hysterectomy. That's the root word for uterus, and hysteria for being crazy around the time of your period. So this is not a new thing. It's been treated differently by different cultures and different religions with varying success, but probably not a lot of addressing the root cause. Unfortunately, we can address the root cause, but our medical system just does not like to do that.
Yeah, I probably would have just answered the question as yes, because you kind of see it as a Venn diagram. And when people want to put you in an either or, I like to push back against that. It's very frustrating for them.
Yeah.
But in any case, we go to the daily symptom chart, and you have anxiety, irritability, depression, nervous tension, mood swings, feeling out of control, poor coordination, insomnia, confusion, headache, crying, fatigue, aches, breast tenderness, cramps, swelling. So I'm sure bloating could be in that same category, and then food cravings. So you have a spectrum of mental effects and then also physical effects that people objectively can see. Like, if your scale goes up 3 pounds or 5 pounds, that's not in your head. This isn't something that is psychiatric, but the secondary symptoms related to that hormone change we alluded to definitely can produce some psychiatric symptoms. So how do we go about diagnosing someone with this? I mean, it seems like 70 or 80% of the population has some combination of those symptoms.
Yeah, so for PMDD specifically, you want to have at least 5 of these, and you want to have them just before your menstrual period. In general, the 1 week before your period, and then within a day or 2 or 3, you want all of those symptoms to significantly improve or completely resolve. So the timing of the symptoms is what matters in this case.
Yeah, and then I think also the severity of the symptoms is what sort of delineates, there's PMS and then PMDD, which technically are 2 separate entities, but it's kind of like a spectrum of how severe the symptoms are. And then an important thing is, is this causing distress in someone's life? So someone can say, oh yeah, I know that my sleep gets a little bit worse. I feel a little bit anxious, but does it affect me at all? No, I'm fine with it. Mm-hmm. Then it's not, pathologic at that point. Same thing with someone's level of libido. Yep. Someone may have a low libido and they don't find it to be problematic, doesn't affect them negatively. Then it's not a pathology. You don't necessarily need to treat that. And then the final portion is, of course, making it a diagnosis of exclusion. It's not related to drug use or another condition, a thyroid condition or POI or bipolar, which also has some cyclical component to it that could be, with a very sloppy history, misdiagnosed.
What about low testosterone in a female? Is that part of the diagnosis of exclusion?
Low testosterone in a female?
Yeah. What if you're on something already that's decreasing your testosterone, like an oral contraceptive pill?
Well, it's convenient then that oral contraceptives are already the treatment for PMDD.
Oh, how convenient. What if you're on what if you have endometriosis and you're on Orlissa?
Well, then you're already chemically castrated. Very convenient.
That's interesting. It kind of reminds me of IBS with irritable bowel syndrome. I remember looking at this huge chart with evidence-based treatments, and you have things that are procholinergic, anticholinergic, serotonergic, anti-serotonergic, dopaminergic, anti-dopaminergic. And you're just thinking,
Mhm.
all right, this is just throwing things at a diagnosis of exclusion and seeing what works.
Yeah, and that's about what you see with IBS. I mean, even acupuncture has some degree of effectiveness. I would say there's also a strong placebo response in
Yep.
someone with IBS. So you switch up a diet, the person gets better. You think that, oh, then that must have been the food that was causing the problem, because there is some overlap between this expectation of GI symptoms. You kind of get into this groove or this cycle.
Mm-hmm.
But not to delve too far, we looked at a chart and just modified it slightly to be more accurate of the normal menstrual cycle. So day 1 through day 28. I think it's very important to note that day 1 is the first day of menses, the first day of bleeding. It's important to clarify that with your patients or with your provider, because I would say most women know this when they're tracking their cycle, but there are a fair number of women who think that the day they stop bleeding is day 1. And that can make your interpretation of the blood work quite confusing. So very important to make sure yourself and the patient are on the same page. So what do we think about this chart here? For reference, what we added was the testosterone level, which is suspiciously missing from most female hormone charts.
Yeah.
And then what I like to call the progesterone roller coaster.
Yeah, I think those are great ways to look at it. I like that we corrected for the units. So if you're looking at the comparison of testosterone and estradiol, given that testosterone directly converts to estradiol via aromatase enzyme, it makes sense to look at both of them in nanograms per deciliter or both of them in picograms per milliliter. A lot of times progesterone is in nanograms per milliliter. That's usually not used, but that's like slightly non-contributory because testosterone and estradiol do not directly convert between progesterone and not. And we don't need to talk about cortisol steal or these other concepts, which really aren't too clinically significant. What is clinically significant is a lot of these treatments will suppress the production of testosterone or the amount of free testosterone that is actively binding throughout the body. The average circulating ratio, as I know we've mentioned many times over the last several years, is that most women have about 3 times as much testosterone as estradiol circulating at any one time. So that's a good thing to keep in mind. If you look at the amount of testosterone that aromatizes, a lot of that has to do with body fat, alcohol consumption, which we'll touch base on later.
Yeah, just going into a little bit more detail in a non-scientific way here at the progesterone roller coaster, you have some people that when they're going up the roller coaster, this increase in progesterone is going to cause some dysphoria. Some people get scared before the first drop.
Mm-hmm.
And then you can see the problem here is that once that progesterone starts to drop, that there's actually no track left.
Yeah.
So at that point, you can imagine that's not going to be a very pleasant experience.
Yeah.
Fortunately, not every woman runs out of track, as it says here, as it would suggest here, whenever you're going down the progesterone roller coaster. And some women are not affected by it, but it seems like it's probably not the majority, but I've seen figures around 40% or so that have some degree of increase in insomnia or anxiety or depression. Those things tend to spike in this luteal phase of the menstrual cycle.
Mm-hmm. And we'll get a bit more into mechanism later. As people know, we're fans of mechanism of action. And progesterone itself is likely not one of the major contributors to this. It's rather the metabolites of progesterone or other progestogens. So progestogens are just any sort of progesterone. So you have pregnenolone, you have progesterone, you have dihydroprogesterone, you have tetrahydroprogesterone or allopregnanolone, and also isoallopregnanolone, another metabolite of progesterone. And in a non-pathologic state, what likely happens is progesterone cascades down into these other progestogens. Some of them activate the GABA A receptor, decreasing anxiety. Some of them inactivate it, decreasing symptoms of depression. Things that bind the GABA A receptor strongly are depressants. You think of alcohol, you think of benzodiazepines. So there's a balance, and conversion of progestogens to its metabolites in a non-pathologic state helps equate the balance with equal conversion to its various metabolites.
Yeah, it seems to center around GABA and GABA-A stability, not having big fluctuations or swings that cause this sort of rebound anxiety. That's why lifestyle is very important around the menstrual cycle, and for those, especially with PMDD, it's very common to note that alcohol can definitely make a small problem worse than it is. I can't say that I've recommended alcohol to improve any health problems, actually, thinking about it.
Yeah, I have not thought of one yet.
All right. So looking at the International Association for Premenstrual Disorders, this actually seems to be a pretty well put together organization. They basically listed out a bulk, not every single study, but a majority of the studies and common methods that are used, and then gave their own sort of rating on the efficacy, the side effects, how it works, and even included some of the sort of non-conventional treatments in their chart here, like the dutasteride, which we kind of called an anti-androgen earlier, because I guess the net effect is less androgenic signaling, so that's kind of fair.